I'm Ron Kennedy Bailey, physician, psychiatrist. I've worked for some time in the field of psychiatry, mental health. I'm a trained forensic specialist over the course of the last 28 years. Finished in medical school, University of Texas in 1990, and I've recently written a book entitled At Gunpoint, a physician psychiatrist perspective on gun violence.
Gun violence is something that's serious in our community, and we hear a lot about mental health tied to gun violence, but can you tell us the truth about that?
Certainly. I think clearly, as my book points out, there's a great deal of misinformation about gun violence in our society. My book attempts to dispel much of that and to elaborate on a great deal of accurate information. First and foremost, we've had a long history of information about guns. We've had a long history where many people think that you have to have a gun for your own safety and protection. In many regards you do. If you live in a rural area, out in the country so to speak, if a bear may walk up to your front door, if you go hunting, you need a long-barreled shotgun. It's a long time to shoot it, but it shoots at a long distance. Those people certainly need guns and certain types of guns for their own safety and protection. But you might not need one if you live in an urban area with many people, small, easily conceal those type things. It's also true that one might need a gun if you're in a setting where you're in the military or in war. I have a son who's in the military, for example, very different setting. Those are appropriate circumstances for guns. But clearly if you have too many guns, as we have in America, 290 million guns, 325 million Americans, all data argues, makes it very clear that the sheer volume of guns, when there are too many of them, there's a greater likelihood there will be too many deaths or early mortality due to guns, too many accidents, too many people who are untrained, too many persons who don't keep guns locked and safely stored, too many mistakes due to guns, too many persons who may have a small conflict, very often interpersonally, with family or friends or neighbors or at work, and they quickly grab a gun to solve a problem that could have been solved without mortality or death. Those are the types of reasons why too many guns, and too many high volume guns, high capacity magazine guns lead to early death and early mortality. Reasons why gun violence in America is extreme and unnecessary.
So earlier you were speaking about 5 truths of gun violence. Can you speak on those again?
Certainly. Well, one of the first things I like to say is that I spent over 2 years studying this particularly, but almost 30 years studying issues of violence. And one misnomer that I like to very often correct is that the gun is the problem. Very often many who maybe haven't studied this issue scientifically or empirically based on data and empirical fact will argue that the gun isn't the problem, just blame the individual. The reality is the gun is the problem. Too many of them volumetrically. The guns themselves very often are not used accurately or correctly, not stored safely. Very often the guns work, they shoot too many bullets at a time. When we had laws, for example, that you could have a gun, the Second Amendment, which is a good amendment. Back then when it was made, very often you'd have a musket, take 100 seconds to shoot 1 bullet. Now you can shoot 100 bullets in 1 second. Very, very different the way it may be used. So the gun is the problem by itself. So we should change the way we actually have access to guns because I think the guns themselves have changed. That's number one. Secondly, very often when we talk about guns, we talk about the people we want to keep away from guns to save society. Good point. But all of our effort is diverted to the wrong persons. Much of the focus is on persons who have mental illness, diagnoses like schizophrenia or schizoaffective disorder or bipolar disorder, the so-called SPMI, or serious or persistent mental illness, the most severely impaired individuals with brain disorders. The reality is those persons are very minusculely greater likelihood of hurting somebody else due to guns, maybe no more than 3 or 4 months, or prior persons where alcohol has been a problem for them. And rarely in most states are there any laws to limit those 3 types of individuals from having access to guns. That's the problem. A third point is we don't really use our technology to our advantage in our society to decrease the scourge of gun violence. There's so-called biotechnology that I was surprised to find out about a few years ago as I read more about it, and I've been involved in this business for a few decades myself. It actually would allow, if our politicians would require it in our society, for guns to be programmed individually to only work if they were programmed such so the person who owned them would be the only person who could actually use it. Think about James Bond, for example, that type of thing. Whereas now anyone can buy a gun but any other person could actually grab it and use it. So sometimes somebody could break into your house and steal your gun and use it against you, or steal it and use it in a commission of another offense. This may actually decrease the value of it being stolen, period, let alone being used against you or someone else in a different type setting. It may substantially decrease its value on the street market, let alone to hurt someone else in a different type setting. So the use of technology to limit its use to hurt others would be of great utility or value. A third point. A fourth point is the entire issue of just decreasing just the sheer volumetric capacity of guns. This idea that there shouldn't be the so-called high capacity magazine. There just shouldn't be, weapons that can shoot multiple rounds and they can pierce armor. Our law enforcement, our police shouldn't be so hyper-militarized because the bad guys, so to speak, whoever you want to describe the bad guys as, have weapons that are more powerful than them. We can't outgun one another. So you should just kind of decrease the volume in that setting. And many recognize that. Everyone can have a AK-47 and an M16 and all these terminologies. We can't keep going to weekend gun shows and buying more and more powerful weapons. You can't have schools with one resource officer, an SRO, and then another and another. This idea that someone allegedly stated that the only way to protect society is for there to be a good guy for every bad guy. At some point, there's not enough guys with guns, if you will. I think science points out, the data points out, that's not a process that's likely to work. So that idea, I think, is a losing construct, and I think the science would argue that substantially. I think the fifth, in my estimation, as a scientist, the strongest point, especially I think in our communities, in many communities, is the idea that we should use academia and science and research to our advantage. We've not done so. Since the 1996 law that was given name credibility, it's called the Dickey Amendment, by a congressperson named Dickey out of the state of Arkansas, that really pushed forward this idea that the federal government would no longer fund or pay for research that might end with the result of supporting any legislation that would have an ending result, that gun reform or limiting access to guns or weapons or what have you would be a good thing. That's had a chilling effect on funding any gun research. So increasingly it's hard to have answers to these kinds of very important questions. And it's actually spurred, in my opinion, other kinds of unfortunate attempts at legislation. I'm sitting in Florida as we speak. We're in 2018. There was an attempt in Florida to pass a law by state legislators, not all, maybe very few who were physicians, for example, let alone mental health professionals or psychiatrists like myself, where they tried to pass a law to actually tell psychiatrists or psychologists what questions we could ask in the midst of a doctor-patient relationship when we're going to assess someone for the prospect of a mental health evaluation and whether you were suicidal or not. Well, I'm a psychiatrist and I've conducted not only hundreds, but over 8,000, if not thousands of those type of evaluations throughout my career. And that's one of the basic tenets of that assessment, to ask someone, are you likely to be suicidal or homicidal? Might you want to hurt or kill yourself or someone else? And one of the tenets of the activity is to find out from that person or a third party, how might one limit the likelihood of doing so by eliminating access to weapons at their home. You may call someone else and say, eliminate all of the weapons at that person's home. If we can't ask about weapons, or I find out if someone else can actually eliminate weapons, let's think about how that's actually going to decrease the likelihood that we can be effective at decreasing the risk of suicide or homicide. So we really have gone down a very unfortunate and potentially dangerous slippery slope, started with the Dickey Amendment in 1996, to hinder even medical professionals from being able to help persons from hurting themselves. So the 5 points are: the gun is a problem. 1, we shouldn't focus on high volume, high capacity, highly dangerous weapons. 2, we should use our science to our advantage to decrease the scourge of gun violence. Use the technology, biotechnology, so guns will only work if you do buy them for the person that bought them, and others can't steal them and use them. 3, 4, we shouldn't overly focus on the mentally ill and overly misidentify or blame them for all these problems. 4, if I didn't point out, we should also recognize that there are twice as many guns used to kill people for suicide about 40,000 every year in this country, versus homicide. So psychiatrists should be the main people speaking at the top of our lungs about this issue, because guns are particularly used for mortality in our primary area where we should be helping people not die, suicide. And the fifth issue is if we can actually allow politicians to make laws to block federal funds for research in an area like gun violence, what if in the future they decide to make laws to block research in other areas of healthcare? What if a politician decided to say, well, I don't want to be told that if I eat too much high-fat food, that may cause diabetes. So you can't do any research that might have an end result that you shouldn't eat high-fat food or high-fried foods, or you shouldn't ride a bicycle without a helmet, or you shouldn't have a car without seatbelts. It's a remarkably slippery slope when you're going to decide you don't want to do research because you don't want a certain result to be the end result, because you don't want to be told that that's or smoke cigarettes because they might lead to lung cancer. That's a very, very bad direction for scientists to be quiet and allow legislators to choose to move down that direction. So I think we have a moral responsibility to speak out actively, assertively, and in my estimation, aggressively about, especially when there's such a huge role to play in harming our community. Those are my 5 or 6 primary points from the book.
Awesome, awesome. Can you speak a little bit about the psychiatry around seeing violence over and over again? You know, I'm sure during your decades of seeing patients, those patients, and now it seems like we're exposed to more violence on TV, online. Can you speak about just how that affects the brain or how that can affect the person?
Certainly. Clearly this idea that there can be this implosion-like effect, tremendous overexposure, and I can certainly dull one's senses, so to speak, clearly has been addressed pretty consistently in the psychiatric or psychological literature, is well documented and well intentioned. Our senses only have so much bandwidth, so to speak, that they can address. It's also very clear that, I mean, I've read in the past that it's estimated that the average child in America from birth until you maybe adulthood may be exposed to, you know, over 100,000 or more acts of violence or scenes of violence from what you hear on the radio or see on television or understand from all the experiences in life, what parents may talk about or what other individuals may see or hear or discuss on the computer, for example. So we live in a potentially very violent society. What you see on television may not always be real violence. Sometimes it is on the evening news, what happened in town that day. Sometimes it's fictional violence. You see it on the cartoons, but it didn't really happen. Or even on a movie. It's play. You watched it and it led to some degree of entertainment, but it was not real. And the next week, that same character is alive again on another show. But still was a violent act and it had some impact on you and it created some reaction, and then you kind of move on. Some level of entertainment, whether it was comedy or made to scare you or at least to some degree of fright. As a psychiatrist, it has a great moment for us. Sometimes it's more than one can take. It overwhelms one's normative defenses or defense mechanisms, may lead to nightmares or fright. Some people can't take it, so they stop going to the scary movie, so to speak. And other times, individuals may decide that they enjoy it and they kind of live for it and need more and more and more. There's some people who need a higher degree of fright and extreme activity to get a rush, so to speak. And you can recognize that has some degree of impact. Clearly, though, some persons then need some other degree, I think, of activity for them to find others who fall in line with them in that setting. Those become the persons who they are friends with or share similar activities with. So it covers the full gamut. But for me as a psychiatrist, I think it's our goal to help individuals find common balance and hopefully do so with a modicum or a minimal degree, I think, of difficulty. Increasingly that's difficult in a time period where there's just so much normative interpersonal violence in everyday life.
Mm-hmm. So from your expert perspective, you spoke a little bit about suicide. And do you see like any trends in suicide? It seems like just outside looking in, like, are there more suicides nowadays? And what's causing that?
Yes, as a psychiatrist, I think one of the unfortunate realities of my career, again, finishing med school in June of 1990, here in Texas, and now we're in the summer of 2018, 28 years later, is that there probably were 30,000 or so suicides, as I recall, then, almost 3 decades ago, maybe less than that, and there are probably 40,000 or so now. At least a 10,000 or so increase, if not a third or so more, a fourth more, a third more. I think that there are key issues. First and foremost, some would argue we may be counting better, that it may be an issue of the distribution of how we actually count them. There was a time in the past that maybe persons wouldn't document it. Maybe someone drove into a tree, there were no skid marks. Maybe it really was a suicide, but it wasn't charted as such. Maybe it was considered an accidental drowning. It really was a suicide. So we may be charting or counting it better. Clearly, though, I think that tools of destruction, such as guns, play a bigger role. We're also seeing more suicides now in demographic groups that historically we didn't think much about suicide. More suicides in women than before. We thought in the past you saw more in men than women. More suicides in ethnic minority groups, like African Americans or Hispanics. Maybe in the past you saw more in other groups, like Caucasians. So changes and increases in those suicides in different groups based on gender or based on race or ethnicity. I do think that you see more suicides increasing now as well, though, because there's just, I think, also a higher degree of lethality and risk also in drugs that people are using. Maybe there's just a higher risk if you're using a more a stronger degree of opioids, or a greater combination of opioids and amphetamines if you're using street drugs. Maybe more accidental suicides in that regard too. So there are definitely more than a variable, one or two variables, I think, that come into play. But that there are more suicides that are documented in 2018 than when I finished medical school in 1990 is very clear. And for those of us who, again, it's our primary responsibility to prevent such early mortality like suicide, especially in young people, particularly like those of us who are psychiatrists, it is an increasing burden and a challenge for us to find better strategies to limit this problem. And the discussion about gun violence, I think, falls right in line with this increasing responsibility.
So the follow-up to that would be for just the everyday person who's maybe a mother or a friend or family member who may think that their family member or friend is suicidal, and they may not be seeking help. What can be done, just initially?
Several things. I think first and foremost, programs like what you're doing now, media, which helps with broad-based education, is invaluable. So let me as a professional thank you as a professional for allowing my profession to enhance its role through your medium. So I thank you for what you're doing. I've done a lot of media in my life, and I like to always do that because it's so important for us to have voice, and it's difficult to do so without this type media venue. Secondly, I think it's also important for families, rather than what may have happened increasingly in times past, which may have been to turn a blind eye and to ignore some early signs of a problem, but to be more proactive, to be more engaged in the lives of their loved one, to move toward early intervention, to get that person to help, to professional care or assessment, to decide, no, this is not good, we're going to go into the doctor, to the emergency room, to get an appointment or whatever, but to do something rather than to wait and do nothing to access a problem. That takes a lot, especially very often because due to all kinds of barriers and obstacles, what we like to often call stigma, and the stigma against having a mental illness often is much more pronounced than any stigma that may exist about having any other kind of illness, a heart problem or diabetes or asthma or even cancer. These problems are substantive. Those are the kind of barriers and obstacles that I've kind of struggled with my entire career, just trying to get people to be willing to accept that their relative may have a brain problem and that it's a problem just like any other organ of the body, the heart, the lung, the kidney, the bone, the lung, if you will, and that they need professional help. I think a third thing that's also key is that we have medicines that work, and somebody needs to hear that. As an African American physician, psychiatrist, I've taken some delight throughout my career in being able to say that to people, and hopefully at some point allow them, I hope that they'll actually hear me and tell them stories about other patients I've had in the past that have taken treatments that have worked. Maybe they've gone from unemployment to working, from being unfunctional to being able to function and maybe live independently, being able to get out of a bad situation, incarceration, to living, on their own and functioning optimally. Those are some of the kind of success stories that you'd hope have some value for some who may have given up hope and not thought they would ever be able to optimally move ahead on their own. So I've had the opportunity to see good success stories, obviously not every time, but sometimes, and those are stories you want to share with people and families as best you can.
Okay. Well, last question. Where can people find your book and find you online?
Good. So we should be on Amazon. It's called At Gunpoint, A Psychiatrist's Perspective. I'm Ron Kennedy Bailey, MD, and I can be reached at www.baileypsych.org or simply ron.bailey@gmail.com.
Okay. So we're putting that out there to our viewers right now. This is where you can reach them. But man, it was so great to have you, a forensic pathologist as well.
I'm a forensic psychiatrist.
Forensic
And I thank you for saying that because all too often people ask the question, well, what is forensics? And all forensics means is medical legal. Mm-hmm. So whenever you're using your medical training to answer legal questions, we call that forensics. Most commonly, the two types of forensic doctors are psychiatry or pathology. Pathologies get the most attention on television because they'll be like this guy named Quincy who was on television years ago. He was a forensic pathologist, and somehow he'd be trying to be the detective on television, trying to solve the crime himself. Most commonly, the pathologist is in the hospital doing the autopsy. But of course, if you're doing an autopsy and you find the problem, if you find a bullet yourself or what the cause of death was, then maybe you could tell the detective, what he could charge. Was it really an aneurysm? Was it really a gunshot wound? Was it really a fall or a bump on the head? What the psychiatrists often do is we assess how the person was thinking and then have to put two and two together, how that may have led to any aberrant behavior that may or may not have been criminal or civil in its underpinnings. So interesting stuff. I like to encourage young people to, go into healthcare, go to medical school, be a physician, psychiatrist. It's been a lot of fun for me, very interesting, good stuff.
All right. Well, you heard it here first at the National Medical Association Conference 2018 with Dr. Ron Bailey. Thanks again.
Thank you.